Okay, sounds good. All right, good morning, everyone. Thank you for joining us today. I'm going to be covering a multitude of different topics about med legal. So just as a disclaimer, I'm not a lawyer, but I do see a lot of med legal topics that come up in different arenas, both as an agency medical director, a base hospital medical director, and then also at the state level. And so many of these topics have been brought forward from your EMS division, questions that come from the field, questions that have come up in different calls. And really, we want to go over all of this and also touch on some of the more recent things that have been in the media as it relates to EMS. So we're going to go over some trends in EMS litigation, considerations for inpatient custody encounters, decision-making capacity, guardianship for POAs, and then some end-of-life care documents. So one of the things I think is important is to look at some litigation in EMS. So every January, I go to the National Association of EMS Physician Conference, and one of the annual speakers there is a lawyer who specializes in EMS. That's his only area of expertise. And so usually what he does each January, he gives us a summary and says, these are the most common lawsuits that we're seeing currently in EMS. And the most common one that they're still seeing really relates to refusals. We know that this is kind of a high-risk encounter, and that's one of the big things that they see as a trend in EMS and continuation. The other thing is documentation, and I think we all know this. This was taught to us in medical school, same thing you guys were taught in paramedic school. If it's not documented, it wasn't done. And so really thorough documentation is always going to be the most protective thing for you. There was also some discussion about telemedicine using audio or videotaping refusals and how protective that can be. One of those things we'll go over a little bit more detail, but just remembering that when you patch and do have that recording of that refusal, especially for something that's a little bit more concerning, it's extremely protective for you. A lot of times when we see complaints that come in, it's a he said, she said scenario. And so we're trying to figure out where in the middle is kind of what actually occurred on scene. So for us, really, to protect you in these situations, it's often helpful to kind of patch when necessary. And the other thing is to look at kind of insurance coverage. So one of the things that I think was highlighted, who's heard of what happened in Colorado in December? So I see one head shaking. So that was when two paramedics were found basically sent to prison for charges related to giving ketamine to an individual that was in custody for with PD. And this was not someone who had committed any crime, and that individual died. And those two paramedics are in prison now for manslaughter. So if you have not heard about that case, it's something to be aware of because there's really a lot of ramifications across the entire country in relation to that. This is one of the reasons why anytime you guys give ketamine, we have kind of strict parameters that we look for. One of the things that we built into the EPCR system is to make sure we have those monitoring things in place, just because it helps to monitor the patient safely. The other key thing that they talked about in this presentation was if you have insurance coverage does not cover criminal charges. So what that means is if something is done while you're working as a paramedic, if there are criminal charges, the criminal charges are not covered by your typical insurance policy. So this is something that was really a key thing, is that criminal charges are separate from any liability coverage. The assumption when you have liability coverage is that there's no criminal act being performed. And so this is something they really wanted to highlight in that presentation. Briefly about refusals, really this is something you guys have sat through with me before, but really all refusals are high risk. Does that mean that every patient needs to be transported to the hospital? Absolutely not. You guys go on a ton of low acuity calls. I've had lots of debates with city attorneys about the benefit or lack of benefit at times for a patch, but just recognize with refusals, we really want to keep in mind that all of these calls have a risk associated. Your documentation is key, so documenting decision-making capacity, the patient encounter, and then having the family or someone else witness the refusal. This is something, again, that last case that Beta shared, there was no witness on that refusal. This was at a facility where, per the complaint that was sent in, there were 6 staff members on scene. So having that additional witness helps demonstrate that the conversation was had, that everyone is in agreement about that refusal occurring. And then just a reminder, no verbal refusals. This is something we really saw kind of take off during COVID. We've reiterated the importance of this. I know you guys see tons of patients that have blood, vomit, puke, poop all over them. Fully appreciate that, but you got to get a written refusal, so some type of signature. So that's why we have cavi wipes, but just making sure you do have a written refusal. A verbal refusal per any attorney does not actually count as a refusal. So are there any emerging trends in refusal documentation? So, online medical direction has and will remain an option. This is very protective for you, as we spoke about. There are some agencies that use videotaping for refusals. The problem with videotaping refusals is that it takes a huge amount of storage space. So it's really not practical, especially with the volume of calls you guys run. It wouldn't be practical for us to save video footage from every single refusal. There was one presentation, and this was done from a large agency in Texas, and they implemented an audio refusal policy where they have kind of a script that they do with all refusals. And what they found is they actually started doing an audio recording of every refusal they went on. And they found there was no increased time on scene for the crews, which I think is key. We don't want to implement something that could increase anyone's time on scene. So they found when they implemented this, no increased time on scene, but they actually found less complaints that were frivolous. And they found that there was less need for online medical direction because oftentimes people felt like I have a really good recording with this patient where they're stating back to me that they understand the risks of refusal, and they felt that that was sufficient for them. Their conclusion from this presentation was they felt it should really be the quote standard of care. This is the first presentation that I've seen done from a large system. Often when you hear some of these pilots being done, it's small systems without a large volume. But this was a very large volume system where they implemented this. So as we look at refusals, we just kind of think about, are there different things we can do to help protect you guys out in the field? So what about inpatient custody encounters? How often do you get called to evaluate a patient who's in police custody? Pretty frequently, right? So are these high-risk calls? I would say yes, absolutely. So I already asked the question, but if you haven't heard, if you just look up, search Colorado paramedic EMS, you will see a litany of articles. This has been going on. It's been all over the national news, EMS literature for the last few years. And really, when you look at what happened there, there's a lot of lessons learned, things that could have been done better or differently. And so hopefully we can take some of those lessons moving forward. Are there things you can do to decrease your risk? So this has been a question that comes up. What can I do to help decrease my risk in these situations? And when you look at the Colorado situation, there were really multiple points of failure. This happened from a state level, there were points of failure, from an agency level, from a medical direction level, from a training perspective, from the EMS providers in the field, and as well as law enforcement. And I've heard different sides of this whole kind of context for this scenario from the state EMS agency perspective, the medical director perspective, the EMS personnel, and then you have the whole trial. And you see that there's many things that could have been done differently. So one of the key things to take away is, as EMS providers, we're there to care for the patient, not law enforcement. So one of the things that came up in this case was law enforcement asked EMS to medicate the patient. And so this is really problematic because one of the things that came up in this case was you guys are the medical providers. You're the paramedic. You should be determining if a patient needs to be medicated, not law enforcement. So that was kind of lesson number one. The also big thing is when you look at the video footage, because of course there's body cam footage of the event, at no point did they really attempt to communicate with the patient. And so again, developing that relationship of you as a paramedic with this individual as a patient, you want to make sure that you try to communicate with them. De-escalation techniques may not work for law enforcement. You guys know that patients encounter you very differently than they do PD, right? There's a different level of trust for the fire service than there is for law enforcement, often from the public. And so sometimes when you go into these scenarios, they may be more willing to de-escalate and speak when it comes to interacting with you than with law enforcement. Another failure point with the Colorado case was a lack of evaluating the patient before they gave medications. So oftentimes if a patient's agitated, you're not going to get a full set of vital signs, right? You're not going to get a blood pressure reading, but there are things that you can document. You can document mental status, you can document work of breathing, you can get a pulse ox. These are some basic things that we need to try to assess. Bending down, at least trying to feel for a radial pulse. Oftentimes these patients are being restrained. You may not be able to get a good blood pressure, but you can generally feel for a pulse. Make sure they've got a pulse, make sure they're breathing adequately. These are some of the things that were not done in that case. And then also the correct medications. So one of the things with the Colorado case is that the patient had a significantly, was overdosed with the dose of ketamine. So they estimated the individual's weight and they were high, like 100 pounds. So obviously in the pre-hospital setting, one of the things that came up in Colorado was people actually said that EMS should weigh a patient before medicating them. This individual had clearly never been in the pre-hospital setting, so we have no way to weigh patients. But there's things you can do, right? Use the crew kind of guesstimate a weight. If you're off by 20, 30 pounds, no one's going to really fault you. If you're off by 100 pounds, that's kind of hard to justify, especially when you're giving a medication like ketamine. So keep in mind, you want to do your best estimate. If law enforcement has an ID, the other thing you can do is also ask them, hey, do you have an ID for the patient? We all know the weight in your driver's license might not be accurate, but at least you're going off something that the patient stated was their weight. So some attempt to get a weight at least as best estimate as possible. So what other things can you do to protect yourself? Number one is show empathy, just really demonstrate that you care. What we know in the medical literature very consistently is that if patients feel like you've cared about them and you're a nice provider, they are much less likely to sue you. When people are a jerk, even if they're good doctors, they're more likely to be sued because people don't like or trust you. And the same is true in the pre-hospital setting. If you show empathy, you treat that individual like a patient, and you show that you're trying to care for them, it's much less likely that people are going to say you didn't care, you were just trying to help the cops, which is kind of what was said in this scenario. So many of the cases where you look at where EMS has been called into question, it's pretty consistent patterns. There was a lack of basic ABCs. So is the patient's airway open? Are they breathing? When a spit hood's being put on a patient, are you still able to assess their breathing? Spit hoods are great. They're great when the patient's yelling and screaming at you. When the patient's no longer yelling and screaming at you, is that spit hood still a good thing to be on the patient? Are you still able to assess their breathing? Can you tell what their airway looks like? So just keep in mind, oftentimes those patients go from extremely agitated and fighting you, and then all of a sudden everything kind of calms down. And when things calm down, that's where everyone kind of goes, okay, we're not fighting this patient any longer. But sometimes what's happened is that patient's clinical status has changed. And so that's why it's really important to continue to monitor the patient. So what about a paradigm shift? So who remembers when we were taught that physical restraints and chemical restraints should be used together? This was something that was taught pretty strong for many years, that if you put someone in restraints, you need to give them meds as well. And we were told this is the safest way to do things. What we found is that the opposite is often true. There's many times people can be physically restrained and you don't need medications in addition. Once you have a physical restraint, there's risks associated with the physical restraints. And then if you add on the chemical restraints, you increase those risks. So what are some of the risks with physical restraints? Well, part of that is positioning. So we do know that if someone's in a prone or lateral positioning, that's obviously very dangerous to the patient. How about if alcohol or drugs are on board, right? That's also going to decrease a patient's respiratory drive. And then obesity. So think about how many times the patient that's agitated that you're responding to is in a lateral or prone position initially. They have drugs or alcohol on board and they're obese. So oftentimes all of those factors are in play with a single individual. Each individual, one of those things increases their chance of respiratory failure. And if you have 2 or 3 of those, you already at high risk for respiratory failure. When on top of that, you then give pharmacologic treatment for sedation, you're going to potentially increase that as well. So with prone positioning, we know that prone positioning is dangerous. I think everyone has been taught this, but we still see this happening. Oftentimes when you guys get on scene, having looked at body cam footage, you see that when you guys are coming up, PD's got the patient's arms around their back, the patient's prone, and they've got a knee on the patient's back. That's a pretty common thing that you see. That's their initial way of getting control of the patient. The problem is that this risk increases and is magnified. So if there's a knee on the patient's back or on their side, that's further compressing their lungs' ability to expand and to breathe. If their hands are secured, again, all those things are changing the patient's normal way of being able to breathe. And body habitus is really a big thing. I think most of us have seen those really heavy patients. When they lay flat, that abdomen just starts to push on their lungs and they have a decreased respiratory drive. And sometimes something as simple as sitting a patient up can help with the patient's breathing. So we know that there's things that we can do. And the key thing is to reposition the patient as soon as a control has been established. And this is something, having watched a lot of body camera footage of both law enforcement and EMS in a combination, this is something that I think we have the opportunity to really improve on. Once we gain control of that patient, the first thing we want to do is to move them into a seated position as soon as possible. Because once you have them in that seated position, you're taking away some of that issues that you have in regards to that respiratory drive. We know that when you look at what causes in custody death, that positional asphyxia is due to prone positioning. So when we have someone in that position, that's really one of the main things that causes that. that is also further compounded with any sedative medication, because obviously the sedative is going to decrease that patient's respiratory drive. So key thing, reposition that patient as soon as possible. So how can we safely use pharmacologic management to treat agitation? So number one, get the patient comfortably positioned, pre-oxygenate. This also works really well as a kind of a spit deterrent. If you can get a non-rebreather on them and you're pumping them full of oxygen, that's great. Often that's not possible, but if you're able to with some patients, that's really helpful. The next big thing, and this is another one of the failure points in Colorado, is have all of your emergency equipment with you. So before you give any type of sedative, make sure you have your airway and resuscitation equipment with you. Make sure you have your monitor in place, because sometimes that patient decompensates really quickly after they get their medications. If you have to go back to the truck to go get your airway supplies or to get your drug box, you're going to be behind the 8 ball. So when you're getting on scene with the patient is agitated and you're going to have to medicate them, just have all your airway supplies on scene, have your monitor ready to go. That way, as soon as you have that patient medicated, you can start that monitoring. The other key thing is make sure you have continuous monitoring. So we really tried to build some safety nets in there, and end-tidal CO2 is one of the best safety nets that we have. If you look at pulse ox versus end-tidal, pulse ox is going to lag behind at least 2 to 3 minutes from where you see a drop in someone's actual oxygen level going low. And this is something that will be detected much more rapidly with your end-tidal. So if someone becomes hypoxic, you may not notice it on the pulse ox reading for about 2 to 3 minutes. And at that point, the patient's been hypoxic for 2 to 3 minutes already. End-tidal is going to pick that up much more readily, which is why we want you to have end-tidal monitoring anytime you give ketamine or any type of benzo as well. So what can we do to try to prevent these events in the future? So number one thing we want to do is really try to work with law enforcement and say, what can we do to kind of help manage these situations better? We want to have a good handoff plan between law enforcement and EMS and work collaboratively together. We have a policy, so make sure you know your policy for restraint management. Make sure you know the policy for your pharmacologic management for agitation, because you don't want in the middle of a call where someone's agitated to have to look at your guideline to figure out what is my dose for medication. So we have a few meds that you can give. Make sure you just have those meds and know the dosing for them. We want to make sure we treat the patient, not the custody issue. This is really important. Whatever reason that patient's in custody, it's kind of irrelevant for us. Joe and I trained at Maricopa Hospital, and we would get a lot of patients from the state hospital. And you kind of tell how bad that individual was with how many guards they came with them. If they came with 4 guards, you knew this person was really dangerous. And sometimes they'd say, do you want to see their folder of why you're here? And I'm like, I have no desire to see why they're in the state hospital. At this point, you don't want anything clouding you. My job is to care for you as a patient and not to worry about whatever got them into the state hospital. And the same thing for you guys in the field. Really, whatever got them arrested, whatever got them in custody, that's a secondary issue. The most important issue is just taking care of them as a patient and determining, is there a medical issue that needs to be addressed? And then make your own assessment of the situation. Don't get anchored by dispatch. I think this is really key. How often is the information that you get from dispatch different from what you get on scene, right? Dispatch does a great job, but they're often getting information from unreliable or frantic callers. And so they're going to gather the best information they can to get you prepared to get on scene. But sometimes when you get on scene, the information you got from dispatch may be very different from the patient you encounter. As I mentioned before, make sure you bring your equipment to the patient. This is something that is really important. I had a recent call that was reviewed from another agency where they got dispatched in the jail for a fall injury. And so they went to the jail. They were like, we're just going to leave the drug box in the car. Well, the patient was initially dispatched as a fall injury because the first officer saw the patient on the ground, ran and went, hey, call EMS. We got a patient down on the ground. They went back to the patient who was on the ground and realized the patient didn't have a pulse. So they started chest compressions. While this was all going on, law enforcement is expecting who's going to get there. EMS crew gets there thinking it's a minor fall injury in the jail. And they get their PDs doing compressions and it has an AED on. They didn't have their drug box. They weren't prepared. So just a reminder, even when it's law enforcement, sometimes just based on the clinical situation, you may have a very different clinical picture from what you were first dispatched to. So the other part is you are the medical provider, make your own assessment of the patient. This is something that I think has changed a lot, but several years ago, we did really see law enforcement asking EMS, hey, can you medicate this patient? Hey, can you sedate this patient? And that conversation, when heard on camera, it's really important to recognize for you guys, you make that determination, not law enforcement. You decide, hey, I'm going to assess this patient. Is it safe for us to medicate this patient? If so, do I have everything ready to go for them? Advocate for the patient. Sometimes this is something as simple as verbalizing on scene. Hey, I just need to check this patient's airway. I need to make sure the patient's breathing. Let me check a quick pulse on this patient. What that does, that audible conversation can reset the scene for everyone and remind everyone, hey, let's quickly check the patient. Let's make sure they're doing okay. Assess the patient, really important component. Get down on the patient's level. Get down on your knees, check the patient, check a pulse, make sure they're breathing. These are basic interventions that really are very protective for you. Patient on the monitor as soon as possible. So recognize that when you've got an agitated patient, you're not getting all the cardiac leads on, that, that's not going to be possible. Can you at least get a pulse ox reading, at least know what the patient's pulse ox and heart rate is before you give medications? But as soon as you're able to, at that point, you want to get the patient on the monitor. The other thing is the 6 rights of medication administration. Anytime just like you learned in paramedic school, making sure that you've got the right medication, the right dose for the patient. Discuss that with your paramedic partner, ensuring that you're giving the right dose for that patient. Kind of confirm, hey, we're estimating this guy's around 180 pounds. That makes however many kilos. This is going to be our dose. That way everyone verbalizes out loud in case someone goes, wait, did you say 180? I think he's probably closer to 140. Let's double check our dosing. So again, that out loud verbalizing on these calls can be very protective for you. Guidelines. So sometimes you may need to give more of a medication. We've tried to make the guidelines to allow you to give more doses without patching, knowing that to patch in the middle of a call with a very agitated patient is difficult. But once you max out for your guidelines, or if you need a repeat dose that's earlier than what the guidelines say, just make sure you patch. Once you have full control of the patient, get them on end tidal, get their pulse ox. This is something that when you watch a lot of the video footage of patients who die in custody, you will see very consistently patients fighting, everyone's struggling to get control. You can see everyone's getting sweaty. They get the patient secured, they get the patient medicated. The patient suddenly goes still, and everyone is like, okay, we got him still, everything's going well. That's the most critical time to get down and assess that patient. Make sure they're breathing, make sure they have a pulse, and having that emergency equipment. If something goes wrong, you're able to at least intervene rapidly. And then document. Understand that these calls are potentially high risk, so make sure you have great documentation as well. So can you clear a patient for law enforcement? Who says yes? Who says no? So the answer is no, but I do recognize that periodically you'll have cops that will call you out and say, hey, I need you to clear this patient for jail. You guys can't do that. It does happen periodically. If you let EMS know, that's something that we can kind of go up through the chain and do a little bit of education. Usually it's just someone who's newer that's coming in thinking that you guys have a different role of what you can do for the patient. A patient in police custody is just like any other patient. They have a right to refuse care and they have a right to decide if they want care. So if the patient wants transport, per statute, they have to be transported regardless of what it is. I am fully aware of the arrestitis, jailitis, whatever you want to call it. It happens all the time. We see these patients in the hospital. Sometimes they stick around and they go through a full evaluation. Other times they get there and within 5 minutes, if PD's not there, they want to leave AMA. Again, I realize that's not my fight to fight. I'm there to just take care of the patient. If the patient does want to refuse care, just make sure you have documentation and then have law enforcement sign as a witness, understanding that they were present as well for this conversation, have them act as a witness for you. So a recent example that I had, which I thought was a really great example, was an EMS agency was called out. Law enforcement went to evict a patient. When they got there, they found a bunch of paraphernalia on scene and a bunch of drugs. The patient complained of chest pain and viral symptoms, and so they called EMS. The fire crew came out. They started to assess the patient. Did a full set of vitals and noticed his initial heart rate was 160 to 180. So they did a 12-lead EKG. They started fluids. They found that he was an SVT. So they started vagal maneuvers, adenosine. That got his heart rate to go from like the 180s to 140s, but it didn't drop below that. So the patient was transported to the hospital. When I asked him what drugs to use, he goes, whatever I can get my hands on. So he was an equal opportunity user, but he was found to have severe sepsis and a significant pneumonia requiring hospitalization. This is a case where really the crew did everything right. Again, they weren't into what was the issue that got him to be involved with law enforcement. They ignored the drug paraphernalia. They basically did vital signs. They found something abnormal and they did the right treatment and intervention. This is a really good example of things that you guys do all the time, but sometimes we see cases where the crews are so focused on whatever legal things going on that you miss the medical component as well. So when you look at illicit drug use, this really increases your risk for severe infection. So we know that patients who use methamphetamines, they have a much higher risk of infection, also higher risk of sepsis. Any IV drug use obviously is going to increase your risk for other infections as well. And what about the chest pain component? I mean, there's lots of different things that cause chest pain. I will tell you that if you look at any sympathomimetic drug, so methamphetamines or cocaine, all of these drugs increase a patient's heart rate and increase a patient's blood pressure. And so that can cause some ischemic symptoms. I've seen an increase in the number of kind of young 20 to 30-year-old patients the last 6 or so months that come into the ED after a weekend. It's Tuesday, and they're still having chest pain. They've got high blood pressure. Their EKG is abnormal, and they had used cocaine recreationally over the weekend. So these drugs have the effect on the heart. So make sure, even if someone's using illicit drugs, always remember that you want to make sure that you are treating them as suspected cardiac etiologies. So next, kind of switch a little bit is keep in mind that you are being recorded at all times. So I think this is something that has really, I think everyone was aware of a few years ago, but the amount of recordings has gone up significantly. This is a good example of just a few of the cameras that you will find out there on scenes. Recognize obviously body camera. Anytime law enforcement is on scene, there's a good chance the body camera's on. This, where you see the picture with the little blue circle in the center, that's a Nest camera in someone's house. I had a recent trauma patient. It was a little 90-year-old lady who had a ground level fall. She's on Coumadin, hit her head. She was stable, but she came in as trauma. Son came in, and after I assessed her, he said, "Oh, let me show you something." He pulls out his cell phone. So she lives by herself. He lives a few doors down. He had called her to see if she was ready for dinner. She didn't answer the phone, so he just went on her cameras in the house that he has and saw that she was on the ground. So after he went over and called 911, he looked at the video footage. And then he showed me the whole footage of what had occurred. He showed me that she was bending over to pick something up, basically tripped, fell forward, and hit her head. So he has the cameras on at all times in her house. So really good example to recognize that cameras are on in people's homes when you go in them. Everything you say and do is on those cameras. The other one is cell phone video. This is something I personally had 2 different occasions where I've caught patients videotaping in the emergency department. The first time was a cardiac arrest. The patient was his mid to late 40s. Mid-resuscitation, I happened to look behind me, and I see the patient's daughter holding a cell phone like this, and she's videotaping us resuscitating her father. So, one of those things that people are often taping you when you would least expect it to occur. I had another one. I was on vacation. I get a phone call and said, "Hey, there's a video of you on YouTube." And I'm like, I'm pretty mild on vacation, but why is there a video of me on YouTube? And it turned out that a patient had actually gone into our ED, and from triage into the room in the ED, and then actually on the floor when he was admitted, he had someone with him that was videotaping each one of those encounters. And they were pretty careful about it. So if you look at it, there's nothing, it was like me doing a neurologic exam. It was pretty benign, but it was still unnerving to know that someone had been in the room, had positioned themselves in an area that I couldn't see, and was videotaping that entire encounter, and had done it very purposely throughout that patient's hospitalization and posted that video. So I kind of share these stories just to give you that awareness. You guys are on camera all the time. Street cameras, another big thing. When you look at a lot of these cases where there's a death in custody, they pull the video footage from everywhere. They pull the video footage from cameras that are on street corners. If there's a store that has security footage that captured that street corner, they pull that video footage as well. This is a picture of some street camera footage. Look at the details and clarity on that video. I mean, it's pretty amazing when you look at today's technology. I put this out there not to scare you guys, but just to be aware. I'm sure you guys all saw the local news in the last year and a half with another EMS agency where it's being shared with things that have been said and done and viewed on video. That becomes part of those cases. So really important, just remember everything that we do and say in both the pre-hospital and hospital setting, assume you are being recorded because it's a good likelihood that you are. One of the things that you see in some, not with these obviously aren't medical cases, but just as often that lack of kind of the ability to treat the patient like a patient and evaluate them. So next we'll move on to some documentation pearl. So this is just a quick slide and some documentation pieces. Again, thorough documentation is really protective. Anytime you document well, that is going to protect you. You want to be aware of pre-selected normals. Pre-selected normals, if you aren't careful and you don't make adjustments to your physical exam and you just kind of go normal, not found, not found, if that is not accurate, that can really be kind of concerning. An example of this would be, has anyone in the room gone through a deposition as a witness? I have. It's pretty terrible, right? Like what do the attorneys try to do? They try to make it seem like you were potentially responsible when you're just a witness, right? Like you were just involved in the patient's care. They're not, you weren't, it's not like a case against you. But what that defense attorney is trying to do is they're trying to get their client off. The way to try to get the client off is by pointing at you and saying that you did something that caused the patient's outcome versus their client. So keep in mind that your documentation, if you have inaccuracies in your documentation, it then makes people question your overall care. So just take the time, have someone quickly look at your documentation, but just be cautious anytime you use the normal or not found on there. Entry and exit wounds. This is just something we were taught in training, never to use the term entry and exit wound. I'm not a ballistic specialist. I don't want to be called a ballistic specialist in testimony. You guys see a lot of gunshot wounds in the field. Just document as a gunshot wound. It was one of the things I asked the EPCR system to be updated so that you guys didn't have to select that. Because one of the things I noticed when we went to image trend, it was gunshot wound entry, gunshot wound exit, which meant you guys had to put one of those down. So I said, let's just change it to gunshot wound. And really what that does is just say you're identifying a gunshot wound and that's it. You're not being called to be the ballistics expert down the road. So determining when a patient can refuse care. So this is something that, I've covered before, but just a quick reminder, I think this is something that we still need to do a little bit of kind of continued education on. The key thing is to remember capacity versus competency. So capacity is what you guys are determining in the field. This is a clinical determination. It's based on a series of questions. And patients with capacity have the ability to make their own decision. So they can make their own decision as to whether they want to have care or refuse care. Competency is a legal standard. We presume that everyone that you encounter has competency unless someone gives you guardianship paperwork on that individual. So competency is a legal standard that means a judge has determined that that individual lacks the ability to make their own decisions. So the presumption when you encounter any adult patient is that that individual has competency. Your job is to determine, do they have capacity? So based on their clinical presentation right now, is this patient able to make their own decisions? So with alcohol and drugs, can a patient who's using drugs or alcohol refuse care? I see a lot of head shakes, absolutely, right? So the key thing is you just got to make sure you assess capacity. There's lots of patients who've been drinking that are able to refuse care. What I do clinically is I just ask them more questions. And that really helps you figure out, you guys know those patients who are just pleasantly buzzed, right? And they're joking and jovial and they're kind of able to answer questions. And you know the ones that are unable to stand up on their own, right? There's a huge difference between those two patients. But then there's the ones that are a little bit in between. They're a little agitated. They're kind of feisty with you. They don't really want to cooperate or answer questions. Those are the individuals that you just have to ask a little bit more questions, because those are the ones that will get you into trouble. Because the patient who's a little agitated, who got in an altercation with someone, you have to make sure they don't have a head injury, right? You have to make sure they have capacity. Well, are they willing to be cooperative and answer questions for you? This is a key thing. I always tell patients, I just put it into their hands. Hey, I'm happy to let you refuse. You have to answer some basic questions for me. That makes them feel like they have an out. And then I just say, listen, let me go through a few questions. Let's try to work through this and make sure that we can let you refuse. Most individuals that will work, if they're really not able to communicate, not willing to communicate, we can't safely determine capacity. So the key thing with alcohol and drugs is to determine, is the patient clinically impaired? So impaired means they don't have capacity. So one of the questions that came up, that this came up in CQI, was they patched for a call and the physician asked, is the individual intoxicated? I don't really know what intoxicated means. That means different things to different people, right? For me, clinically, I want to know, is the patient impaired? Impaired means, can they make their own decision or not? And so there's a big difference. Someone who's intoxicated, meaning that they've been drinking, but they're able to answer all orientation questions, they can explain the risks and benefits. They may be intoxicated, but not impaired. So the key thing is, is the patient impaired, not is the patient intoxicated? So that's how I kind of like to look at patients who've been drinking. is determining that. That really helps to determine that decision-making capacity. So the question I get in follow-up was, how do I determine if someone's impaired? That's that, can the patient stand on their own? Can they make eye contact with you? Can they answer basic orientation questions? And are they able to communicate all risks back to you? So that's the difference of impaired versus intoxication. If you're not sure, that's when you contact online medical direction. That's your backup for that. So what about dementia patients? So dementia patients can absolutely refuse care at times, but again, really need to be a little bit more cautious. Many patients are diagnosed with dementia and are still able to initially work and be self-sufficient. This is especially true with patients who have a family history of dementia. They may go and get tested earlier and be found to have kind of early signs of dementia. The medications that are used to, quote, treat dementia don't actually treat it. They're more of a preventative medication. So for someone with a strong family history, they may get this diagnosis and go on one of these preventative medications. With someone with dementia, they may have something clinically going on that's going to worsen their capacity and ability to make their own decisions at that time. So it's a time of day. In the morning when they're fresh and awake, they may be much more with it and be able to answer questions. But now that it's 9 o'clock at night, they may have some sundowners and not be able to answer those same questions. So time of day may be important for a patient with dementia. Things like infection, do they have a UTI or electrolyte disturbance? Those things are going to make them more confused. So if you get that diagnosis of dementia, just make sure you really go through your orientation questions and going through the risks and benefits with the patient. So capacity is not a blanket term. It really applies to this specific point in time. And there's a lot of patient encounters you guys go on where a patient's going to go from lacking capacity completely to regaining complete capacity. An example of this would be someone who you go to with altered mental status and their blood sugar is critical low. You give them dextrose and they regain capacity. Another example would be someone who has an opioid overdose. You give them naloxone and they regain capacity when they wake up and oriented times 4. Another one would be a patient who's post-ictal from a seizure. When you get there, many of those patients are very confused and unable to refuse. But once they become more awake and alert, they exit that post-ictal state. That patient often is able to make that determination they want to refuse care. So those are just some examples of where capacity just in a single patient encounter can vary quite a bit. For patients with dementia, if a decision is more complex, they may have to bring their family in to help make that decision. They may be able to make a simple decision like, do I want to go to the hospital or not? Versus a decision like, do I need to have surgery, which is much more complex and they need to understand more complicated risks and benefits. So guardianship and POA. So this, I'm just going to go over a little bit of key terminology just because there's a little bit of confusion that sometimes comes up. And many times the confusion actually comes from the patient's family members and what they tell you on scene. So a guardian is someone who has the legal authority to care for another individual. So that could be a parent or a court-appointed guardian. So the presumption is that an adult patient would not have a guardian. A conservator is an individual who has control over that patient's finances. So sometimes you'll hear people use those terms interchangeably, but a guardian basically makes the decisions on that patient versus a conservator that's going to handle that individual's finances. In order for that person to have a guardian, they have to lack capacity or be incapacitated. So that means they lack the ability to make their own decisions. The guardians are appointed by a court. So again, this is someone who is appointed by a court. So if you're handed guardianship paperwork at a care facility or a group home, that means that patient is not able to make their own decisions. So it's really important. If someone has a guardian, you have to talk to that guardian in order to make a determination about patient care. So that's a big difference between guardianship versus a power of attorney. Guardianship means that individual is no longer able to make their own decisions at all. So this more commonly applies to someone who has developmental delay and often with someone with advanced dementia or an individual in a group home. This is kind of the general powers and duties of guardian, and it really talks about this is the exact statutory language, but a guardian is an individual that is appointed that has the same rights, duties, and powers of a parent, essentially. So that's a good way to think about a guardian. This is someone who has the same rights towards that patient that a parent would have towards their child. So kind of a nice way to think about that. So in regards to a vulnerable adult, this is again some of the legal terminology, but a vulnerable adult is essentially someone who is at risk for any type of exploitation, abuse, or neglect. These individuals, if you suspect any potential abuse or neglect, you are mandatory reporters, and this is one of the things that EMS asked me to really focus on, is just reminding everyone about the importance of statutorily as medical providers, we are required to report any suspected abuse or neglect. There's two really easy ways to do that. One easy way is to notify law enforcement and write down the badge number of the law enforcement officer that you've given that report to. That's probably the simplest and easiest way to do it. The other option is to do a direct report to APS or DCS. The APS ones are for adults that can be done online. So we did update the guideline because someone in the field had recognized that the hyperlink to that was not working. So if you wanted to do a direct report, you could via the app. The other option with DCS is that is a phone call. Sometimes those wait times can be really long. And so really the key thing is to make sure you meet one of two reporting requirements. So either law enforcement with a badge number documented or directly to APS or DCS. Any questions about that piece at all? Notification to the hospital does not count. That's probably an important thing to mention. It's important to share your concerns with the hospital just so that the hospital can make sure that they're not potentially discharging that patient back to that unsafe environment. But the notification to the hospital does not suffice as your mandatory reporting requirement. So in regards to power of attorneys, this is something, let's see, stop advancing there. All right. So power of attorney, so this is an important distinction. So as opposed to a guardianship, which is in place all the time, a power of attorney only goes into place when that individual lacks the ability to make their own decisions. So many of you may have someone who's your power of attorney, or you may be a family member's power of attorney. I have someone who's my power of attorney. I'm power of attorney for multiple family members. That's only when that individual lacks the ability to make their own decisions. So if someone has something that's going on medically and they can't make their own decisions, that's when a power of attorney paperwork comes into place. The part that is tricky is, especially on scene, sometimes you guys will get dispatched to a call. The patient wants to refuse care and the POA says, I want the patient transported. So that is not an infrequent event. And that's when you just have to determine, does this patient at this time lack capacity? Because if that patient has capacity, the power of attorney doesn't have any decision-making ability. So that's kind of the big difference of a POA versus a guardian. So if someone is on scene and they say, I'm the POA or I'm on the phone and I want them transported, and the patient is adamant that they do not want to be transported, but you feel that patient has capacity, that's another really good example where you want to probably just share that decision with the patch phone physician as well. So have that conversation on the patch phone. So again, just a reminder, POA only comes into play when the patient lacks capacity. This can be temporary or permanent. So sometimes a patient may have something going on acutely at this time that prevents their ability to make their own decisions. So someone has a medical event, they're intubated, they obviously can't communicate. Their POA is going to be their decision maker. Once that patient gets extubated and they regain capacity, that patient is then able to communicate again. They go back to being their own decision maker. So just because a power of attorney is effective, it doesn't mean it's permanently effective. It's really effective for that point in time that the patient lacks capacity. So a little bit about advanced directives. So there are several types of advanced directives. There's the actual advanced directives documents, the POLST form, the pre-hospital DNR form, or the orange form, and a living will. A living will I won't cover a lot just because most of those are pretty complicated. They're more of a legal document and often hard to determine in the pre-hospital setting. So if you're interested, these are the statutes that apply. Some people like to see the statutes that actually give them protection to follow the orange DNR form. That's on the bottom there. It's ARS 3251. So the types of DNR forms that you may see out there. So there's the most common one everyone thinks about is the orange DNR form. The actual name of this is the Arizona Pre-Hospital Medical Care Directive. There's also the POLST and the MOLST, and I'll go over theirs as well. And then you'll see a document that oftentimes is just listed as an advanced directives or living will. These can all be stored in the advanced directives registry. So this is something that is actually patients can access. They can upload their documents directly into this registry. It's connected to the Health Information Exchange. And there's a big push currently to try to get EMS access to this registry. So they're doing two pilots, agencies in Arizona. So kind of two small fire departments that are part of this pilot, where EMS is going to be given direct access to this registry so that if you had a patient's name or date of birth, you could search for them to see if they had advanced directives in there. The other thing I just found out that is available, just in case someone gives you one of these cards, is it's like a little almost ID card and has a QR code. And the QR code, if you scan that with your phone, will take you directly into that patient's advanced directive registry, and they could have the pre-hospital DNR form with the, in that registry. So if someone gives you a card and says, my DNR is on this card, and you see a little QR code, that is legit. I'd never heard of this before, but this is part of this kind of process to try to increase access to DNR forms and to make sure we're honoring patients' wishes. It makes sense if you think about it. Many times patients' DNR forms, it's going to be at home or wherever they reside. So if they're out running errands and something happens, that may not be readily available. People don't typically travel with their orange form with them. So if you do see that and you kind of open with the QR code, it should bring up the actual orange form, and then you can honor that as well. This is the statutory language. I put in all of the statutory language. I'm not going to read that to you, but I'm going to highlight the key portions of this. So the DNR form comes into play when a patient is in cardiac or respiratory arrest. So the key thing is cardiac or respiratory arrest. It does not authorize withholding care if someone still has a pulse. So if someone has a DNR and they have a pulse, they're still breathing, they still get treatment. This really goes into play only when that patient goes into cardiac or respiratory distress. It has to be in an orange background, and it can either be a letter or wallet size. So it can be either size. And there's actually a bracelet that's also available. So this is something that a patient may have an orange bracelet if they have a valid DNR form. The orange bracelet has to be orange and have these key things. Do not resuscitate, the patient's name, and the patient's physician's name. So those are the key things that have to be on an orange DNR bracelet. You're most likely to encounter these at a care facility, especially a large care facility. If a patient goes down in the dining room, they're probably not going to be in their room where their DNR is. But if they have that orange DNR bracelet on and that it has the information that matches the patient, you can honor that orange DNR bracelet. So this is the part of the statute that specifically refers to EMS and the immunity regarding this. And so I think this is really well-written statute because it's very protective. It basically says if you in the pre-hospital setting make a good faith effort to determine that this patient matches this DNR, you are immune from any liability. So if you honor that patient's DNR, you are felt to be immune, and that's very well laid out in statute. So the key thing is making sure that you have the patient's name, and that matches the DNR, that there's the appropriate signature on there. Kind of important part of that. So this is the pulse form for the physician's order for life-sustaining treatment. So this is a little bit newer form. You will start to see more of these out there. And the reason for this is that this form is really designed as more of a transition for patients who are kind of nearing the last couple of years of life, and they want to make a determination about what kinds of care they want done. The key part of the pulse form is the conversation between the patient, their family, and their healthcare provider, because it's really going through kind of step by step, what kind of interventions would I want done? So if you look at this, you can see, check it out. I don't know if that's shown there, but at the top, you can see obviously the DNR status. It then goes from the DNR status to say if the patient is breathing and has a pulse, what kind of treatments do you want? It then gets into any special considerations. People can write in things like, I don't want a blood transfusion, or I do want a blood transfusion, I don't want dialysis. So it gets into very specific interventions. And then it gets into medically assisted nutrition. So for a patient who has maybe a terminal diagnosis or patient with longstanding dementia, this actually gives the patient and their family the option to really kind of outline what types of care they want in the last few more years of life. So this is a valid document as well. This is the back of the form that gets into just the signature requirements for that. The MOLST form is very similar. This is not formally recognized in Arizona, but you will see, obviously, with our snowbird population, you have patients that come from other states. The PULST and the MOLST are really felt to be a kind of a superior document to a simple DNR form. So with our patient population, where many people come from other states, you may see family members that give you one of these documents, and they want you to honor that. The key thing to remember is that the orange DNR form, you can honor without patching. So that gives you the ability to simply honor the DNR form and take no further action, no patches needed. If a family member gives you a PULST, MOLST, or advanced directives, any of those, you need to patch for permission to follow that. So certainly if someone gives you this and they say, hey, they really didn't want compressions done or they didn't want resuscitation, you just need a patch to get permission to honor that because it's not the pre-hospital orange DNR form. Any questions about that? I know that comes up occasionally. Yes. I'm sorry, say that again. No, orange bracelet counts. So if they have the orange bracelet, that means that they have a valid DNR. Yes, thank you. So in order to get the orange bracelet, that means that they have the orange form to back that up. I mean, if you can, you can. Otherwise, I see Veda going like this, take a picture of the bracelet, just like you would kind of the actual form itself. So that's another great option. You know, it's one of those things where depending on where the patient is in relation to where the form's stored, if you're in the dining hall and they're at the other end of the campus is where their room is and where the form's stored, it's not going to be probably realistic to go all the way to get the form. But if they have that bracelet, then that means that they have the valid form to back it up. Any other questions on that? Yes. Yes. So if someone's on scene saying we don't want anything done, but they don't have any documentation, can you patch? Yes, absolutely. If they're saying they have a form or they don't have a form. If they say we have a form, we're just trying to find it, we have the orange form, that you could probably withhold. If they say we don't have any documentation, but we don't want resuscitation done, you have to at least start compressions, you know, passive oxygenation and patch, because you don't have any documentation. If there's some signed document that they're just trying to locate for you, with that setting, you can withhold and patch. So if they say they have something signed, they're just trying to locate it, you can withhold. If they don't have anything signed, but they say these are our wishes, basically minimal intervention, so compressions, passive oxygenation, and patch. You agree with that, Joe? Yes. So I did a ton of searching trying to figure out where that 2 minutes came from. Like, was there some legal standard or statute? And I don't know where it came from originally. It was in there and it just kind of perpetuated along. And so the reason we took that out was we didn't have any legal basis to put that on. I think it's kind of a reasonable time frame to give people 2 minutes to find something to patch. But you know, if someone says we have an orange form, you know that there's a pretty good chance that they have it, right? You can still, you know, patch in the interim while they're trying to find it if they don't have it on scene. If they can't produce it at all, that's going to be really the comfort level of the physician on the patch phone. And, you know, also you guys can kind of read the room. If it's like the patient's spouse and they're like, no, we have signed DNR forms and I know it, I just don't know where it is, versus someone who maybe doesn't seem like a good historian, or it's like a caregiver versus a family member. So I think sometimes gauging who's the individual giving you that information. If it's a spouse, you can feel pretty comfortable that that person knows those wishes and they probably have a form. A caregiver may not be as accurate or reliable in that situation. If they're saying that they have a form and they're trying to find it, yes. Yeah. But yes, the 2 minutes, when we were updating the guidelines, I really tried to find where that came from and we couldn't find it anywhere. I think it just somehow got put in there as like a reasonable option. And so it just kind of continued along. All right, so last slide. So really in summary, just a reminder, show empathy, especially with any patient, with those patients in custody, show that patient some empathy, just treat them like a patient. Rethink how you proceed with management of agitated patients. We have had some high-risk incidents that have occurred here in the city. Just remember that you're on camera. There's tons of body camera footage. If there's 6 officers on scene, there's 6 different body cameras that are seeing you from every different angle. So really just reevaluate how you encounter those patients, making sure you treat them as a patient, evaluate them, assess them, do good monitoring of them as well. Document. Remember, you're on camera wherever you are in any patient encounter. And when in doubt, contact online medical direction. And that is it. Yes. Great question, because I actually just got a patch like this. Yes, the patient still has their rights. Whether they're in jail, prison, they still have their own rights for refusal of care. So I would just patch in that situation just because if the jail wants them transported. But yes, they still have their rights regarding medical care. Yeah, great question, because that just came up last week as a patch. Any other questions regarding patient positioning, agitated patients in custody encounters? All right. Thank you, everyone.